My name is Laura. I will be moderating our session tonight on bunion pain and bunion correction. The presentation and Q&A session are not intended to address any personal issues that you may have. Our goal this evening is to just provide you with some general information about bunion pain and bunion treatment to help you make an informed decision about your health. We will have a question and answer session following the presentation, so if you would like to save your questions for the end, that is okay. Our online seminar tonight is being recorded, so all of our attendees will receive an email copy of the recorded seminar, and we will also have this posted to our Excela Health website and Excela Health Facebook page. We will also have an opportunity for you at the very end this evening if you are interested in scheduling an appointment with Dr. Flanigan to address any personal concerns or issues you may have. We will give you that option. So if that's something that you are interested in doing, please stick around after the presentation and we will be able to assist you. Okay, so as I mentioned, our featured presenter tonight is Dr. Ryan Flanigan. Dr. Flanigan has been with the Excela Health Medical Group since 2014, so he's been on staff with us for 6 years now, and he is part of Excela Health's Orthopedics and Sports Medicine service line. Dr. Flanigan attended medical school at the University of Rochester School of Medicine and Dentistry in New York. He completed his residency and fellowship at the University of Rochester Medical Center in New York for orthopedic surgery, and he also completed an additional fellowship at Mount Sinai Medical Center in New York City, New York, specializing in foot and ankle care. So, Dr. Flanigan, we're so excited to have you with us today. And at this time, I'm going to stop sharing my screen so I can allow you to share your presentation with everybody.
Thank you very much for giving me a little bit of your time tonight. Appreciate the opportunity to share with you a procedure that I'm pretty excited about that we've been able to bring to Westmoreland County here in the last couple of years. Brief outline what we're going to cover today. So a little bit about me. Laura did a pretty good job with that, but a little bit about me and my background. We're going to talk about what a bunion is. We're going to talk about the problems with traditional bunion surgery and how this new procedure, which is called Lapiplasty, can address these issues for us. So as Laura said, she covered most of this. This is a medical procedure we're talking about. Individual results will certainly vary. And our conversation tonight does not discuss a consultation with a qualified surgeon who can evaluate your individual situation and give you the best advice. But hopefully it can give you a little bit of a baseline here of what's available. Of note, I do serve as a consultant for the company with the product that we're going to talk about tonight. My job with them basically involves teaching other physicians how to do the procedure, which I do a few times a year. I have no other incentive to use or recommend their product, but it's actually a nice one to recommend because I believe in it, and it's worked very well for my patients thus far. So a little bit about me. I am an orthopedic foot and ankle surgeon, different from a podiatrist. Podiatry is its own school, much like chiropractic. Orthopedic foot and ankle, as Laura said, we do a residency covering the entirety of orthopedics. And then subsequently, I did additional training as a fellow in foot and ankle surgery in specific. I am a born and bred Pittsburgher. I grew up and attended high school in the South Hills. I have family hailing from West Mifflin, McKeesport area, as well as Upper St. Clair. Myself and my family currently reside in Greensburg. I have a wife and 2 children, and we make Greensburg our home, so we're part of this community here as well. Education-wise, as Laura mentioned, I went to the University of Notre Dame as an undergrad, finished in 2003. Subsequently spent a lot of time in Rochester, New York for medical school, finishing in 2007, and did my orthopedic residency there as well, finishing in 2013. And the picture on the right is beautiful Rochester. That looks like probably about a summer night in August. For a lot of the year, it looks like this. So I enjoyed it, but I was very happy to come to a little bit more of a temperate climate. We get a little less snow. I finished my education at Mount Sinai in New York City, where I was a foot and ankle fellow and finishing in 2014. And as Laura said, I've been with Excela Health since that point and have made Western Pennsylvania my home once again. So as a confession, I actually never liked treating bunions. They were not my favorite through training or through the beginning of my practice here. And really it's because it's a difficult problem. They're hard to fix. They're fairly poorly understood, to be honest with you. Recurrence is common. If you look through the literature, there's about 80 plus procedures described on how to fix bunions, which means that we don't have a great answer on what the best one is. Or I should say we didn't have an answer, but I think we're getting closer to that answer now. They also have a bad reputation. I have a lot of patients come in and tell me, oh, I heard bunion surgery is terrible. It's a long recovery. It's painful. You're off your feet for a long period of time. And the good news is I think we're able to address some of those issues better now than we were in the past. And most importantly to me, patients weren't always happy. Even when you get a nice outcome, it looks good. some patients still had pain. And while that's still certainly a possibility, I think, again, it's something that we can address better now than we could in the past. So what I did initially, I tried to treat patients without surgery where I could. Bunions are difficult problems to fix without surgery. You could try to adjust shoe wear. You can limit activities to a degree. When surgery was necessary, the mainstay of our treatment truly was taking a straight bone. The bunion is not an abnormality of the bone. The bone is still straight, but we would take a straight bone and we would make it curved, which never sat well with me. This idea never made sense. It's the only place in the body we really did that. And so it really prompted me to continue looking for a better answer and a better solution for these problems. So let's talk a little bit about what a bunion is. So a bunion definition is a painful swelling and deformity of the big toe joint. And essentially you can see that the big toe bends towards the other toe. So on this patient, their left foot, but on your right, obviously represents a bunion, whereas on your left side, you're seeing a toe that's essentially normal. So what it's not, a lot of patients are under the conception that this is a bump on the toe or an extra bone. It is truly not an extra bone. It is a normal bone. It is just in an abnormal position. People also say it's an arthritic joint. That's partially correct. You can have arthritis with a bunion. You can have both, but they are truly separate entities. And when you do have both, that actually changes how we address these a bit. It is truly this prominence of a normal bone is what a bunion is. So they vary in severity. Starting on the left side there, that's a relatively mild bunion. You see the bump there, progressing all the way towards what you see on the right side, which is obviously a relatively severe bunion. The severity, the deformity does not necessarily correspond to pain. So I certainly see patients on the right-hand side of that picture with minimal pain, where I see patients on the left-hand side with a lot of pain. It is possible still to have a mild bunion and have a lot of pain. So pain is our determining factor in what we do, not so much what it looks like. Bunion symptoms, generally pain, swelling, pressure and numbness, particularly over that prominence on the inside of the foot, and often worse in tighter shoes when the toes are being forced to be crowded, often worse when you've been standing on it for a long period of time. So the causes, the bottom line is we really don't know what causes these. There is certainly a genetic component to it. Biomechanically, there is a problem with the joint, but it's not the joint you think. The shape of the joint, and it's actually the next joint up in the foot, which I'll show you on the x-rays, but the shape of the joint here is, I think, the abnormality that leads to bunion. We like to blame this for a long period of time on women's footwear, tight shoes, for instance, high heels. And while those may play a role, those may aggravate and accelerate the deformity, it's not the cause. Generally occurs more in females than males. And an interesting thing is there's a genetic component, like I said. We see this even in cultures that don't wear shoes. They've looked at this in Aboriginal cultures, and even there, people do have bunions. So certainly a big genetic cause to it. So a lot of times you could probably thank your mother for it. So I guess, can bunions go away? And the short answer is no. They really don't go away on their own. But if you Google it, as I did here and posted a few things, you're going to find a lot of things that tell you otherwise. This website tries to tell you how to dissolve your bunions naturally. This website is actually selling shoes that say they're going to treat your bunions without surgery easier than you think, which was news to me. You'll see a lot of splinting. Amazon sells a lot of splints. And I tell patients when they talk to me about this, I have no issue with patients using splints. A lot of times it will make you feel more comfortable. It will remove some of that prominence pain. But it is not going to correct this. It's not going to make this go away. That said, if it makes your pain better, helps you be more functional, there's nothing wrong with using a splint. But just I get upset when these promise things they can't deliver, such as making it go away, which, again, I have not seen a non-operative way to do this. So I'm just the messenger, but they are progressive. They don't go away on their own. You can treat them without surgery, however, and again, as I mentioned earlier, the decision here is on when to do surgery is based on pain. So I do have patients come in with a deformity and they say, I don't like how it looks. My advice is generally in those situations not to do surgery. It is one of those situations, if it doesn't hurt you, it's always possible to make it hurt. But when it hurts, I do think surgery is a viable option. Now, things you can do without surgery, toe spacers, padding or splinting, inserts can sometimes be helpful. Changes in shoe wear, generally a shoe that has a wide, what we call toe box. It doesn't rub on those shoes. A shoe with a mesh upper that's not, again, going to confine or rub can be helpful. And then modifying your activities, which essentially means reducing what you do. Of course, a lot of my patients aren't really excited about those ideas. The reality of this is a complex deformity, and my belief is that they're caused by an unstable joint in the middle of the foot. So it's not so much the joint that we see the abnormality at, but sort of the next joint down in the foot. As the picture on the right shows you, that's the unstable joint that I think leads to a lot of this. And what it does is that as that joint allows these bones to move, they drift out of alignment, and they create this prominence that we call a bunion. So on an x-ray, this is what they look like. A normal foot's there on the left. If you look at the big toe, you can see that it is well lined up. It is pretty straight. Those two dots underneath the big toe are called the sesamoid bones. Those are totally normal. They should be there. If you compare that on the right, however, you can see that that toe is actually drifted towards the inside. And in response, the toe itself moves closer to the other toes. If you also look at those sesamoids, you'll see that they've actually rotated. They've shifted position. And that's indicative that that bone is actually rotating as well. And of course, there's the deformity. So that brings us to surgery. So surgery is an option for bunions, obviously. And like I said, there's a high number of ways that have been described to fix these. So what's wrong with our traditional bunion surgery? And I admit this is what I used to do when I started practicing. The answer is we're treating what is a three-dimensional deformity with a two-dimensional surgery. So 87% of bunions are malaligned in 3 dimensions. So that means that the bone is actually turned, it's elevated, and it's rotated. And we're going to show that in the next slides here. So a useful analogy here is Leaning Tower of Pisa. So this occurs because of an unstable foundation, same reason that the tower is leaning. The bone leans sideways, and you can see where that arrow points out, that's how it drifts outwards. While it does that, it actually elevates a bit too. So the toe angles upwards a bit in relation to where it should be. It also rotates, and I think this is a nice picture. Just as the tires on a car can change alignment, or can rotate or shift with a bad alignment, the toe does this similarly, and those sesamoid bones are the key here. As they rotate, you start to see them between the first and the second toe, which is not the position they should be in. So that, again, shows us that rotational deformity on an x-ray. So traditionally with surgery, what we would do is shave down the bunion, which is what you'll hear a lot of people will tell me the surgery they had, they shaved down my bunion. That is what they do. So just on that right picture, you see we basically lop off that prominent area of bone. The problem with that is it really does nothing to address the foundation, the unstable part of the bone, pointed out there on that picture. The next thing you do with surgery is after you shave down that bone, you actually make a cut in the bone and you shift that bone towards the inside, towards the outside of the foot. Again, by doing so, the tower is a good analogy there and kind of shows you that idea. It doesn't address that unstable joint. And again, we're taking a bone that was straight and now we're making it curved, which is kind of an odd thing to do when you think about it. So now we have a crooked bone and the joint remains unstable. So again, nowhere else in the body that we do this, and you can see those pictures kind of indicating that presence of the unstable joint still. So a lot of times these can actually look good though. You see the picture on the left, that's after a bunion correction. Doesn't look bad. The bump is gone, and these are somewhat successful. People do get some pain relief from these. It does remove the prominence, but there's a very high risk of recurrence with these. And my own personal belief is that a lot of the bunions we see that come back are because it wasn't fixed in the 3rd dimension. We know from studies that fixing those sesamoids, getting that alignment, that car, fixing those tires, getting that realigned is the key to longevity in these corrections. And that's one thing I don't think in the past we were able to do well, but I think we're able to do better now. So studies show us there's a 12 times higher likelihood of recurrence if you're not addressing those 3-dimensional deformities. 1 in 3 patients remain dissatisfied after a standard bunion correction, and about 70% of them get some level of recurrence. That doesn't mean necessarily they're having more surgery, but it isn't where they left it, or where the surgeon left it at the time of surgery. So these are the problems that we faced with traditional surgery. So a Lapiplasty procedure tries to address all 3 of these, and in my opinion, does an excellent job really getting that adjustment for us. So a little bit about to understand a Lapiplasty, you need to understand where it came from. And where it came from is a procedure called the Lapidus procedure. A Lapidus procedure is a fusion of the first tarsal metatarsal joint, that abnormal, that unstable joint I pointed out to you on other pictures. That's the joint that we focus on here. So what we do there is we open it up, we realign it, we remove the cartilage, we realign the bones, and we put something in to hold it in place, usually plates and screws. The goal there is to get those bones to heal together. So everyone gets worried when I talk about fusions in the office because they say, oh, my foot's not going to move. It's not going to be a normal foot. I'm going to walk on a stiff board. That is not the case here. This joint is actually what we consider to be an expendable joint. It is not a motion joint. You don't get much motion from that even when it's working properly. And the problem with the bunion is that that joint is no longer working properly. So sacrificing it or fusing it, in my opinion, makes a lot of sense here for this problem. So the Lapidus procedure was described a long time ago. It was first described in 1934 by a surgeon named Paul Lapidus. It's been discussed as controversial over the year. And if you Google Lapidus procedure, you'll find some sources that talk about this controversy. It's been in and out of favor, but as technology has improved over the years, it's become more of a go-to, particularly for the worst bunions we would see. It is a powerful procedure. It allows us to get a lot of corrections. People with bad deformities, this is a good option for them and was traditionally part of what we did. As that technology has evolved, though, we've gotten better and better results from it. It wasn't until the 1970s we started being able to have implantable screws that really worked well here. It wasn't until the 2000s that we got plates, which I think added another level of ability to correct and encourage these bones to fuse. And 2015 is when we started focusing on this 3D correction. So again, that's the unstable joint we're focusing on there. That's that tarsal metatarsal joint. So again, this is a new take. The Lapiplasty is a new take on an established procedure. It addresses some of those problems. For instance, it allows me to get a preview of the correction. Before I make any cuts in the bones, I know what the correction is going to look like, which is a huge advantage versus trying to eyeball it and figure it out how much I should cut on my own. It's reproducible. Total joints are a gold standard for us in orthopedic surgery. If you line up a total joint well, most people do extremely well. We never had that level of precision with foot and ankle surgery. This allows us to, again, do a reproducible bone cut. So every time I cut that bone, I know what I'm getting before I do it. I know if I cut it the same way, I'm going to get that result I want. It also allows me to do a 3D correction, which is, in my opinion, what was really lacking versus what we used to do. I did a lot of Lapidus surgery when I started, did a lot through my training, and that third dimension, getting that rotational deformity back where it belongs, was always difficult. And I think Lapiplasty allows me to do that in a way that other systems did not, other hardware did not. It also allows me to get my patients walking on it faster, which satisfies them and makes them happier. So it is a 3D correction. So just like using that the tower analogy again, we're correcting it from the base. This picture, that animation, shows one of the devices we use to help correct that, help realign that toe and hold it in position. So we're restoring the natural anatomy here, and we're rotating the toe at the same time to fix that rotational abnormality. The procedure works like this. So again, that top picture on the right, you see that we've returned the alignment there. Particularly, I'm not sure if you can see my pointer, but these sesamoid bones right here are back where they belong underneath the big toe. Next picture down there shows the cut guide. So we're able to align that. We check its alignment under X-ray, make sure we like what we're going to cut, and then we cut it. We clean out the joint, and then we put something on to hold it in place, which are the plates and screws depicted here. So it allows me, again, to template that correction, to have a correction ready to go before I make any cuts, before I commit to anything. It allows me to fine-tune it, which is great. So this shows a picture with the hardware in place. So we permanently secure that joint, put in plates and screws to address that and get it to heal together. And I think we're addressing the deformity then at the source. Picture from the operating room showing what it looks like. That's what it looks like under the X-ray. When we have the joint aligned, you can see how nicely it's lined up with reference to that second toe, how straight it is, no bump present there. And then the cut guide in place, and then what the hardware looks like on the right-hand side. There's some before and after pictures. This shows you, a before bunion and an after bunion. And the things I want to point out there, the bump at the big toe joint up here, where everyone thinks the traditional bunion, is gone. The alignment of this bone is about close to that bone, and those sesamoids are back underneath the big toe where they belong, not peeking out the side here where they were before. So again, we get normal motion still at that big toe joint. So that joint still moves, much more important joint in terms of walking normally and without pain. And then we get a fusion, ideally, at that TMT joint, which gives us stability. Good news is I'm a data person. I believe in doing things that are proven by the literature, and there is data out on this now. We've been studying this for a couple years. There's 13 plus studies, and I actually think that's quite a few more versus actually when this slide was created. But they're showing upwards of 97% success in maintaining correction, meaning correction you leave the operating room is the correction you have at a year and a half. I have no reason to believe that's not going to persist. I'm pretty optimistic that once we get a fusion of that joint, the deformity is really unlikely to recur. Some examples. These are patients from the company. I have a few of my own x-rays at the end to show. But before and after surgery, you can see where the incisions are here over the top of the foot, and then a small incision in the web space between the toes. Nice alignment there, removal of that bump. Same kind of idea here. You see that same incision on the top of the foot and then between the toes. Again, a very nice alignment, removal of that bump. And then a third one, basically showing the same thing. So we get reproducibly nice alignment here for people. This is what the hardware looks like. People often ask me what it looks like. These are the ones I typically use. They're anatomically contoured, meaning they're shaped to fit the bone. They're locking screws, meaning they actually join into the plate, so they are very unlikely to back out. They fit the joint. They're low profile, so they're unlikely to bother you, unlikely to irritate. I take out hardware very rarely with these. I think I've taken out 1 or 2 of these out of almost 100 I've done so far. They're made of titanium. We angle them about 90 degrees from one another, so we get correction in 2 separate planes. And again, relatively rare that we need to remove them. So when we compare this to other techniques, I'll show you what those x-rays look like to give you an idea here. So this is a traditional Lapidus on the left-hand side. This is what I used to do. We get some decent correction there. The bump is gone. We did shave down some bone on the inside of the joint there. But if you can, again, I'm not sure if you're seeing my pointer, but this area here, the sesamoids are not corrected 100%, which tells me there's still some rotation there that wasn't fixed. Whereas the Lapiplasty, as comparison, you can see much better correction. This is the traditional cut and shift. And again, taking a straight bone, making it curved doesn't make a whole lot of sense to me. Here, we're keeping your straight bone and we're realigning it. And again, that joint is not addressed. There's been a big push in the last few years of minimally invasive surgery. Minimally invasive surgery is a very sexy surgery. People like it because it's little incisions and less recovery. However, I have a real hard time understanding the logistics here. This is kind of taking that cut shift and making it and putting it on steroids. You can see how much they shift that big toe bone. And yes, they're able to do that through small incisions. But again, we're taking a bone that is straight and we're making it curved now. And that, again, doesn't sit well with me. I don't like that idea. There's nowhere else in the body that we do that. Finally, I want to talk a little bit about recovery. So everyone asks me about this. This is obviously very important to patients, and I think another advantage with the Lapiplasty. So usually about 2 weeks, I allow people to start weight bearing on it. First 2 weeks, I like you to take it easy, ice elevate, and we'll go through that. But at 6 weeks, I'm moving you back into shoes. And 3 to 6 months, you can start resuming activity. So what this looks like for the first 2 weeks, usually tip on some pain medicine for a few days. You're in a splint or a boot. And again, a little bit of that depends, on what else we do. Often we're fixing toes with this, so that often requires a little bit more protection. But in general, you're off your foot for about the first 2 weeks. The dressing I put on stays on. We ask you to elevate. We ask you to take aspirin to reduce the risk of blood clots. And basically you rest and ice it to try to keep the swelling down. You come back for your first post-op visit about 10 to 14 days. First time you get to see kind of what things are looking like. As long as the incision looks good, we take out the stitches. We allow you to start weight bearing at that point, typically in a boot. We expect bruising. We expect swelling. That's normal and really can persist up to 6 months to a year. But most of the time becomes asymptomatic before that point. Again, encouraging rest and ice and allow you to begin working on some motion. Between 2 and 6 weeks, you start feeling a little bit better. Swelling and tingling remains. That is normal. You're walking in the boot. You're resting, ice, continuing on the aspirin. You can start to get the foot wet, at least around the area of the incision with a washcloth and such. And we start with exercise. I don't typically formally use physical therapy for this. However, if there were a reason to do physical therapy, certainly would make sense. Then at 6 weeks, we allow you to progress into a walking shoe. Generally, an athletic shoe is good at about 6 weeks, as long as the swelling allows for it. You can start driving again if it was your right foot that we did. We allow people to stand while they're in the shower with nothing on the foot, obviously. You can elevate, rest, and ice. Discontinue the aspirin now that you're out of the boot, and start some light exercise. And then usually 3 months, you're allowed to start increasing your activity. You can progress shoe wear, so you can start getting back to shoes of your choosing. Although I generally still do recommend a good supportive shoe. I wouldn't recommend stilettos even at that point, or very high heels. But you can start progressing to a more normal shoe wear. Still recommend elevating the foot. It will still swell, and again, that's normal, resting and icing when you can. And then 4 months, we start to remove the activities. You can start walking barefoot when you feel ready. Compression socks or stockings can still be helpful. Swelling is still normal and can still occur at that point. Doesn't usually worry me as long as things are healing and the x-rays look good. And typical final follow-up in about the 6-month time frame. So again, as with any treatment, individual results do vary. There are risks and recovery takes time. The risk with this surgery, infections, always a risk anytime we do surgery. Discomfort from the hardware, loosening of the hardware. It's always possible the bone could fail to heal. We call that a non-union. That's pretty rare. The risk in the study so far shows less than about 2 to 3%. There's always a chance there could be loss of correction, but again, relatively rare with this system, certainly less than what we were seeing in the past. It's always possible additional treatment could be needed. So my experience with Lapiplasty, we've done nearly 100 Lapiplasty procedures over the last 2.5 years. This picture is actually from the operating room, myself and Carly Russo, who is a PA that works with me as an integral part of our team, both with the surgery and with the rehabilitation. Anybody that ends up seeing me, you'll get to know myself and Carly quite well. We are the most experienced team doing this in Westmoreland County. We're actually in the top 3 in the Western Pennsylvania region as far as our volume and how many we're doing. So we've got the experience, and we do a lot of these, which certainly I think makes you better at it. As I noted before, I do actually serve as a presenter and instructor for lab courses for the company as well. So part of my task with that, which I really enjoy, is getting to go and teach other surgeons how to do this procedure and how to do it well. Excela is a market leader. We are a market leader with this procedure. We are a center of excellence at this point. And I'd like to point out that the procedure is actually not available within UPMC and is very limited availability within Allegheny Health. So I really appreciate the commitment Excela has made to allowing me to offer what I think is truly a evolutionary, if not a revolutionary procedure in treating bunions here in Westmoreland County. Why I like it, in summary here, this allows me to fix a problem at what I believe is the source. It's a reproducible procedure. I get a better, more reliable correction, and as a patient, you get a straighter toe because of it. The cut guides make this formulaic. They make it like a total joint, which is something I think we need to strive for with other procedures as well. There's a higher likelihood of fusion here, which means a lower risk of having to reoperate. And I think patients do better in terms of pain. I think it allows them a safer and earlier return to weight bearing. And the bottom line, as a surgeon, patients are happier. And when they're happier, I'm happier, and I sleep better at night. That concludes our formal presentation. I'd be happy to answer any questions. I did mention I have a couple of my own pictures here. These are our own cases from Westmoreland County that we've done. You can see some nice correction there, how much of that bunion we were able to get to go away for that person. Another one on a left side there. Again, a very nice correction with that hardware we talked about. And then a third one, a relatively severe bunion with some really notable rotation there. You can see that sesamoid bone sticking between the toes. We're able to get those realigned, get this nice and straight, and these patients did very well. So again, I'd be happy to answer any questions for anyone here. I thank you for taking the time to join us tonight. And again, happy to answer any questions. Happy to see anybody. As Laura mentioned, we do have some appointment times available specifically for people who attended the webinar. So if this is something you'd like to talk with me more about and see if you'd be a candidate, be happy to see you and we can get you in. Thank you very much. And Laura, happy to answer any questions that came in.
So I just wanted to let everybody know that Dr. Flanigan does have office locations in both the Latrobe and North Huntington areas. He does practice out at Excela Square at Norwin, as well as Excela Square at Latrobe. So if you are within those areas, those regions, you will have an opportunity to see Dr. Flanigan at one of his office locations here. So, okay, so now we're going to go into our question and answer section. So, is there a bunion that is too severe to be treated?
That's a great question. In general, the answer is no. The caveat there, as I mentioned briefly in the presentation, when bunions get real severe, oftentimes we will also see an arthritic joint. I do think having an arthritic joint at that abnormality does change what you should do a little bit. So it really depends on the degree of the arthritis there, but there's no severity here, I think, that can't be improved. I always tell people we can't make it 100% of a normal foot, but we try to get it as close as we can. And I think the more severe it is, obviously it's tougher to get back to that normal. But that said, no, if a bunion is present and causing pain, there is typically something we can do that's going to improve that pain for the person.
What are the most common misdiagnoses of bunions?
That's a great question. I would say arthritis is the big one. A lot of times people do have arthritis of that joint and get, have a bump on the top of their foot and will say, I have a bunion there, when in reality what they have is arthritis. And that's a different way to approach this. That would be a different approach to address that problem. I'd say that's probably the number one. There are other conditions that go with bunions as far as alignment issues with the foot and toes, that sometimes those need to be addressed as well with fixing the bunion. So I don't know if you call that a true misdiagnosis. Gout sometimes comes up. A lot of patients will have a red swollen toe and they get diagnosed with gout, but it doesn't really improve things. And you find, it's really just more of an alignment issue. I would think those are probably the most common ones we see.
Now, are there any age limitations to bunion correction?
With Lapiplasty, they're actually approved all the way down through age 12. That said, in younger patients, especially patients who still have open growth plates, that does change the procedure. There is an entity called juvenile bunions, juvenile idiopathic bunions, which can affect people at a younger age, obviously. The approach to that may be a little bit different. Again, if they have open growth plates, that can change it a bit. But we have FDA approval with the system we're using, the Lapiplasty, to go down to age 12. And doctors can go off-label in appropriate situations. So there's no real age on the lower end that says we can't do something. But it certainly is an individual decision, would be a discussion on what the right approach is. On the upper end, there's truly not an upper end. I've used I've done a Lapiplasty all the way through people in their 80s. Again, I think the criteria is pain and difficulty with activity. So if somebody's having trouble wearing reasonable shoes, I think it's reasonable to try to correct that for them, assuming they're healthy otherwise, assuming they're still active, assuming they've tried, other shoes, for instance, and other things to try to make it better first. But there's no strict age limits here. But the majority of our patients with this are probably between 25 and 65.
Am I able to have bunion correction on both feet at the same time?
Yeah, that's a great question. That comes up a lot. Is it physically possible? It is. My general recommendation is not to do that, though. I'm a firm believer you need one good leg to stand on. If we're doing both sides, that really is going to hamper your mobility. And while, it is something that could be talked about, I would generally strongly advise against it, except in a extreme situation, something that puts you at risk for undergoing a second surgery. In general, my recommendation would be against doing both together. I would try to do them separately.
Is a burning sensation in the foot a diagnosis of a potential bunion forming?
So that's a great question, too. It can be, is the answer. Burning is generally a nerve-type pain. So when patients start using words with me like burning, numbness, tingling, electrical, that almost always means a nerve-type pain. Now, nerve pain can come from a variety of sources. If you have a deformity and that deformity is pressing or irritating on that nerve, then yes, burning can be associated with bunions. That said, there are other reasons that could go along with that as well. It could be a nerve entrapment or a nerve compression. It could be neuropathy, where the nerves, such as in diabetics, where the nerves start acting inappropriately over time. So burning certainly doesn't signify that it is a bunion, but burning can come along with a bunion.
I know you had mentioned a little bit about when someone might be able to either drive or return to work. Would that be a case-by-case basis? I know you said individual results may vary, and I know you said it's about six weeks to a month or two before driving or working, but is there any leeway with that, or would you say it's case-by-case?
It's definitely case by case, but in general, driving, if it's your left foot, driving is really when you're off your pain medicine. If it's the right foot, my recommendation is generally 6 weeks. It's about that long before things have healed enough. I tell people that you can panic stop, that you can get to the brake quick enough, hit it hard enough. I want to make sure you're safe to yourself and safe to others on the road, obviously. Work is a little bit of a different question. It really depends on what you do. If you're seated most of the day at work, it is possible you could go back relatively quickly. If you're in a labor job where you're on your feet all day, then I think it's going to be towards the longer end. If you're in a job they say you have to be back in your steel-toe shoes, it may be 6 to 8 weeks before you're able to be on it all day and be back in that shoe wear. So again, it's going to vary based on the person and their occupation. But it is something we address on a case-by-case basis, and our goal is to get patients back to doing what they want as soon as they can and as safely as they can.
What kind of scarring can someone expect using Lapiplasty versus regular bunion surgery?
That's a very interesting question. Scarring is very individual. I sometimes joke with patients, some scars look beautiful and some look, not so beautiful. A lot of it has to do with how your body heals it. A lot of it, honestly, from a surgeon perspective, is outside of my control. That said, there are some things we do to try to minimize the scars and make them look as nice as we can for people. But I always emphasize, this is not a cosmetic surgery. This is a functional surgery. This is a surgery we're doing to relieve pain. I will do everything in my power to make it look good for you as well. But, if you have an ugly scar and your foot doesn't hurt, that's a success. And we can certainly address, those could be readdressed if it happened. And we've done that on occasion. But, there are some choices in the suture we can use for people that are prone to that. They generally know that they are prone to ugly scars. And there's some suture choices we can make that may assist with that. But in general, again, it's one of those things that is very much related to the individual, as I've learned.
Someone has had bunion surgery already. Will this be a problem if they're considering this new type of bunion correction?
Yeah, that's an excellent, and I see that a lot actually, because a lot of people have had some form of bunion correction. As we mentioned, they're unhappy with it. They still have a deformity. They're still having pain. In general, Lapiplasty is still an option for those patients, especially patients that have that traditional cut and shift surgery. We can often do a Lapiplasty there and significantly improve the situation for them. So no, having previous surgery is not necessarily a contraindication, a reason you can't have this done. Again, it's something that we need to be evaluated, discussed, and kind of decided upon. But in general, we can do this as a revision correction. And in fact, I've had a lot of success doing that for people that were unhappy with their initial corrections or continue to have problems.
Thank you to everybody for attending our presentation this evening. Dr. Flanigan, we want to thank you again so much for this great information about this new type of bunion correction. We've learned a lot this evening, so thank you again for being with us.